I'm Dr. Mandeep Mehra from the Mass General Brigham campus here in Boston, Massachusetts, welcoming you back to Heart Failure Minutes. Today we focus on an emerging and potentially practice-shaping framework in the management of acute decompensated heart failure, a novel classification of decongestion built on three mechanistic pillars: renal tropism, renal bypass, and renal relaxation. To unpack this paradigm, I'm joined by Dr. Milica Vukićević, a Harvey scholar here at Mass General Brigham, whose recent commentary on the venous heart failure early feasibility study highlights how venting of the venous circulation may offer a new therapeutic handle in a field where outcomes have stagnated despite decades of progress in chronic heart failure. Well, Milica, for years we have relied almost exclusively on loop diuretics at the bedside and then, of course, vasodilators as indicated. Yet outcomes in acute decompensated heart failure haven't really budged. Why is the traditional approach insufficient, and what motivated this tripartite framework of renal tropism, renal bypass, and renal relaxation?
Well, the unifying culprit in acute decompensation and decompensated heart failure is congestion. And more than 90% of the admissions involve it. And on the other hand, the residual congestion at discharge is one of the strongest predictors of adverse outcomes. So the problem is that our tools haven't matched the pathology. Until recently, we have two main pathways for decongestion. So the first is the renal tropism therapies by using diuretics to push the kidney harder. But if renal perfusion is impaired, venous pressures are elevated, and diuretic responsiveness gets blunted. So the next would be renal bypass strategies like ultrafiltration that physically removes fluid but haven't shown consistent benefit and often provoke renal dysfunction since we don't have measures to optimize the fluid removal. So we now believe that just escalating all therapies is insufficient, and understanding where they fail and where alternative mechanisms might succeed is definitely needed. So our new proposed framework adds a third mechanism of renal relaxation, relief of renal venous hypertension through modulation of venous return, reducing right-sided pressures and improving perfusion gradients. So this third category, renal relaxation, is actually where the venous HF early feasibility study breaks new ground.
So the venous HF study is the first practical test of this novel concept that you propose of renal relaxation through mechanical preload modulation without a change in actual volume intravascularly, using intermittent occlusion of the superior vena cava using a balloon. Walk us through what makes this different and why its mechanistic insight actually matters.
Well, in venous HF, use of the precardial system to intermittently occlude the SVC targets the venous circulation itself rather than the kidney or the intravascular volume. So the SVC accounts for about 30% of intravascular volume, and the venous return, and the device vents this venous return by using a balloon occlusion for 5-minute occlusion intervals with brief 30 seconds or so releases. So in the early feasibility study, this has been shown to produce various hemodynamic effects that reduce preload, enhance renal perfusion pressure, and during active therapy actually increases diuresis. So this method acts actually as a mechanical throttle, allowing the failing right ventricle to catch up by modulating, not removing flow. So I like to describe this as renal relaxation because the kidneys finally see relief from the venous hypertension that suffocates their ability to excrete sodium and water.
Well, this paradigm is quite elegant, Milica, but we still live in a world with diuretics at the bedside. That's all we have mostly in most cases. How should a clinician integrate this knowledge of renal tropism, renal bypass, and renal relaxation into contemporary practice? How should we anticipate the future for this?
Well, clinicians should definitely treat this framework as both as a guide for current strategy and therapy and as a roadmap for future innovation. So the first point would be the start with renal tropism, which means that diuretics actually remain the first line, but their limitations should be recognized on time and early. Second point would be actually the use of renal bypass selectively. What does it mean? Ultrafiltration remains appropriate when diuretic resistance is present, but we must acknowledge its mixed clinical track record. And the third point would be definitely the prepare for the renal relaxation to become the third pillar. Which means that if ongoing pivotal trials confirm that intermittent preload mechanism and modulation is safe and that it can shorten the hospitalization or improve decongestion, we will finally have a targeted therapy for venous congestion. Of course, some questions remain, such as durability, neurological safety from intermittent jugular pressure elevation, and whether short periods of preload regulation can shift long-term outcomes. But as a proof of concept, venous HF shows that the venous circulation itself may be a therapeutic target in acute decompensated heart failure.
Well, thank you so much, Dr. Vukićević, for defining a very fresh and very thoughtful way to understand decongestion in acute heart failure. One that is not just rooted in physiology or pharmacology, but in a much more deeper and insightful understanding of how to tackle decongestion. I'm also pleased that you expressed some of the challenges and the limitations of this technology moving forward, and we will stay tuned for that. The renal tropism, renal bypass, renal relaxation framework gives us a much more honest and precise vocabulary, in my opinion, for what we are doing to the kidney and the venous circulation in tandem during decongestion efforts in episodes of decompensation. As new devices such as the Precardia device move through pivotal testing, this paradigm, in my opinion, may reshape how we think about congestion itself. Well, this is Dr. Mandeep Mehra signing off from Heart Failure Minutes. Until next time.